but it's actually, radial component, excuse me, but it's got a power chain attached to the little hooks. You sometimes use composite just to flow them on. What that will actually do is it'll allow the patient, this is somebody else now, to have a much thinner labelled bow. And all of this time, when we have got gaps in the front teeth and we're retracting, we also remove the lingual bow altogether completely. Okay? If you do that, what you're going to do two things. First, you're going to reduce the countering force, so you're going to just increase that movement, the speed of that movement. And secondly, it's going to feel a lot nicer for the patient because they've not got this lump behind their front teeth. So you often find when you fit these, patients just talk perfectly well. They're like, this is cool. Unfortunately, as soon as these teeth start to touch, like Amy's are now, you've then got to put the palatal bow back in. So in this case, you can see the teeth are touching. I'll show you before in a minute. You've got to put it back in. If you don't put it back in, then there's a risk that you're going to buckle and one tooth is going to come too palatal. Okay? So this patient, so Amy's teeth had gaps before, then we closed the gaps down without the lingual bow, then we put the bow back in as soon as they touch. The teeth are still procline and they're going to need more IPR to come back in. Okay. This patient, you can see here, there's no lingual bow on it currently, and we're just using a power chain. We use a power chain, we fully close the teeth down. In fact, we didn't even need a palatal bow because once we got to here, everything was touching nicely, position was good, then we just went ahead and restored them